Yes. Yeah, macular papular just means you have this irregular shape patch of red, usually red.
Oh, it's usually red.
Yeah, it's usually red. And then in the siblings, there's all these little papules. They're supposed to belong to that.
Okay, so if it's just plain like that and there's not the little bumps, then it's just the macula. But if there's a bump and
It's very rare. It's more common than that.
so then that would be macula. Okay. And then I have another question. Sorry, one last question.
No problem. So if you're looking at it, so this one has these areas. It's kind of hard to see in the photograph, but this would be like all those little flat macula areas, and then there's all these little bumps.
Yeah, it does look like measles though. That's why.
The measles looks more like, I'll show you.
That lighter pink.
Yeah, they're all about the same size. Measles, they're all little bumps that are about the same size. I'll show you a picture later.
Okay. And then for the skin testing, so this is, I'm having, so this one is to see whether they will have a reaction or not, and that's when you go see an allergist and they prick your skin and the test, right? But whereas this one is if they'll have, if they've had an allergy and...
Well, say they say, I'm going to get penicillin and you want to get penicillin, there's no alternative. Then you can refer them to the allergist to rule out whether they are truly penicillin allergic or not. So it's to rule out whether they are. Unfortunately, you're going to miss 10% of they really are. So if you do the skin test and it's positive, that's definite. You don't want to get penicillin. But if it's not positive, then you do this. You do the graded challenge to follow up. So it can be follow up to the negative skin test.
Okay, and then...
If you react to that...
This is both done by the allergist?
Yeah.
Okay.
All right. All right. You all hear me? Is it working? There have been a lot of questions about maculopapular. Macula is a flat, reddened area. It can be irregularly shaped, any kind of size. Then interspersed among that, either in that macular area, are all these little bumps of various sizes. That's the papules. So maculopapular is a very common form of reaction. If I was to ask an exam question, what's the most common form of skin drug reaction morphology? This would be it. Second would be the morbilliform.
or meso-like, which doesn't look anything like this. It's all, meso-like is all these little tiny bumps interspersed everywhere and all of the same size. You'll see a picture of that in a little bit. Okay, remember we talked about the different mechanisms? You have the non-immune, which would be direct toxicity and mast cell degranulation, also known as pseudoallergy. Quite a few drugs are in this category. Starting off with photosensitivity reactions. This is a broad term encompassing two types of reactions: phototoxicity and photoallergy. As you can well imagine, the phototoxicity is non-immune. Photoallergy is immune reaction. And you should be able to differentiate the two, because it's really important to differentiate them in terms of whether you can give the drug again or not. If it's the phototoxicity, it's drug dose and UV light dose dependent. So in other words, the more you take of the drug and the more time you spend in the sun, the more time you'll have this photosensitive reaction. You get erythema and edema. It looks like an exaggerated sunburn. And here's two pictures. Severe cases, you may get some vesicles or a little bullseye, in other words, some blisters, and it may be itchy. That's probably be the case with something where you're out in the sun for a long period of time and you're taking a pretty healthy dose of whatever the offending drug is. It can occur within minutes of exposure to the UV light. So you're on doxycycline, which is a tetracycline. You go out in the sun for a couple of minutes, come back in, and 20 minutes later your face is all red. That's phototoxicity. You don't necessarily have to stop the drug. You just have to stop the exposure to ultraviolet light. And the rash is confined to the area exposed to ultraviolet light. So if you're wearing protective clothing or a pretty good sunscreen, the reaction won't occur. What are the offending agents? The antifungals as a group, antimicrobials, particularly the tetracyclines, and that's minocycline and doxycycline. Tetracycline by itself is not even available in this country except in veterinary medicine. We don't give it to humans anymore, at least in this country. It is still available as tetracycline, which is a specific tetracycline, and then there's the tetracycline class of drugs, which minocycline and doxycycline are in that class. Certain cardiac drugs, and amiodarone is tops on the list. Diuretics like furosemide and hydrochlorothiazide. Again, I'm probably giving you some drug names that you haven't studied yet, but like I said, print this out, keep it for future reference. NSAIDs, the ibuprofen, the ketoprofen, the naproxen, and most of those are sold over the counter, right? Motrin, Advil. CNS agents, phenothiazines are not used as much anymore, but back in the only psychiatric drugs we had back in the 70s and 80s were the phenothiazines and the tricyclic antidepressants. Fortunately, they're not used as much anymore. But I remember at Langley Porter at UC San Francisco, the patients who were put on chlorpromazine, which was thorazine, the number one phenothiazine used in psychiatric hospitals in the 70s, they would wheel the patients out onto a patio in the sunlight and put an umbrella over them. Topicals like 5-FU, 5-fluorouracil cream, and the retinoids, the types of drugs that are used topically for acne, can cause a phototoxic reaction. If I was to make an exam question from this slide, what do you suppose the question would be? Multiple choice. Which of the following drugs can cause phototoxicity. And I'd list a bunch of drugs, and you would pick one out. It's on this list. Most likely would be a tetracycline, amiodarone, or a phenothiazine, because I made them bold. Right? All right. Here's photoallergy. This is the immune reaction. Fortunately, a lower incidence than with phototoxicity, so you don't see it as often. But it's not dose related, not at all. And it's a type 3, I think it's type 3 or type 4, type 4 cell immune response with activation of T lymphocytes. So it's delayed in its onset. It's not like the toxicity where a few minutes in the sun, you come in and 20 minutes later you're sunburned. This one, you're taking the drug and you get this very exaggerated sunburn, almost to the point of a dermatitis. And here's a couple of pictures. Very severe. It can spread beyond the sites that were exposed to the sun, and it could be very itchy. And in this case, you can't give that drug again because they have developed an immune response to the drug. So they can't get it again. And it's usually more than one exposure is required because the first time you're exposed to the drug, you build up that immunity. No drug, and then the second time you're given it, the reaction occurs. Unless, of course, you're put on the drug and you're on it for weeks or months, the likelihood of it causing that reaction is greater. Remember, we talked about prolonged frequent exposure. So, this one, of all ironic things, the agents they put in sunscreens cause this reaction. The number one, 25 years ago, the number one sunscreen agent found in practically every Sea and Ski, Coppertone, all of the major brands of sunscreens contained PABA, para-amino benzoic acid. It no longer exists in this country. Can't say on the internet or some other country they still have it as a sunscreen agent. But look at the sunscreen ingredients. Avoid the benzophenones, which is oxybenzone, which is a popular one in a lot of sunscreens. Shouldn't be given to children. You'll get a photoallergy reaction. Some of the salicylates as well. Now, a lot of the other, I don't know, there must be 30 or 40 different sunscreen chemicals that you'll find in a lot of these products. But avoid the PABA you should be able to avoid because it's been taken out of the American market. But benzophenones are still there. Some of the non-steroidals, see the little asterisk? Unfortunately, the same drugs that caused phototoxicity also can cause photoallergy. And that includes ketoprofen, (5-FU topical, a couple of the antifungals. And here's a unique agent that isn't prescribed a whole lot, but you'll see it occasionally. Dapsone. I think it's used for leprosy and other infective conditions. Phenothiazines, again, pop up. Again, their use has dropped off dramatically. And then here's probably the most common, fragrances, particularly musk. So if you ask a patient, what's your aftershave lotion, and it's one that contains musk, and they've got a photoallergy reaction on their face from using shaving lotion, be suspect of that. Some fragrance in that product is causing the photoallergy. So what's your counseling points? Of course, avoid the sunlight, if possible. Wear a sunscreen of SPF 30 or greater. Wear protective clothing. There's a lot on the internet patients could buy. If they're going to be on the medication for a while, this is suggested anytime they go out in the sun. Sunglasses are important. Baseball caps have a very low SPF of only 3. They don't protect you very well. And then you would treat with the topical steroids, emollients, and wet compresses, similar to what you've probably already discussed in your other lectures, OTC products. All right, here's another skin reaction that's non-immune. Pigmentation of the skin. It takes on many different colors. Here's a tetracycline-induced discoloration. Any child under the age of 9 years old should never be given any tetracycline. Doxycycline, minocycline, what have you, that's available. Because what happens is it deposits in the permanent teeth underneath the baby teeth. And when the permanent teeth come out, this is what they look like. Permanently stained. The picture on the right is chloasma or melasma from prolonged use of phenytoin, the anticonvulsant dilantin. You get this brown, tan discoloration on the skin. And sometimes this pigmentation is aggravated by UV sunlight, as you'll see in some of the examples. So on the list for causing this, amiodarone, Smurf disease. We'll talk about it in more detail in a minute. The antimalarial agents, particularly hydroxychloroquine, you get this gray, blue, black pigmentation of the skin. There's a picture there. And this is about 25% incidence, so that's 1 in 4. Phenytoin, we already mentioned, the brown discoloration. And then here are the anti-infectives. Minocycline is on this list. You're going to see minocycline a lot. It causes a blue-gray pigmentation of the skin. Chemotherapy, there are certain chemotherapy agents you can get pigmentation of the skin. Got them listed